only in non-diabetic individuals, not in diabetic individuals. So only those people who are non-diabetic and they have hyperglycemia in the intensive care unit. And how do you define that hyperglycemia? As per the American Diabetic Association, is what we look at the benchmarks where it's more than 140 or an HbA1c of more than 6.5%. So an HbA1c of more than 6.5% or a blood glucose of more than 140 milligram per dl, this would be considered as hyperglycemia. So when a person who is non-diabetic goes to these levels, non-diabetic goes to these levels being in the intensive care unit, their incidence of morbidity, mortality is higher than those who are diabetic. This is very important, okay, very, very important. So what does this mean? That you probably want to control the non-diabetic much better than those patients who are diabetic. That means a little bit of leeway for diabetic patients is acceptable. A little bit of leeway for diabetic patients is acceptable, but for a non-diabetic patient this is not acceptable because it clearly causes a change in the mortality and morbidity. Clear? Now, also what you must understand is what is the usual rate of sugar diabetes in the entire population? What do you think? How many 100 people are there? How many would be diabetic? Say if 100 people are there in a population, how many would be diabetic? 2.8%. Okay, only 2. So 2.8 in 100 are actually diabetic. Okay, in a whole population of 100 people, maybe only 2.8 to 3 are actually diabetic. Okay, but when you come to the intensive care unit, what happens is the incidence of hyperglycemia there is 15 to 20% when it comes to intensive care unit. So this is a big difference. It's almost 10 times. You understand? So those people who come from in the periphery in the hospital, there 2.8% of them will have high sugar. So it's okay monitoring them once a while when they're in the hospital. But when they come to the intensive care unit, 1 in 3, 1 in 4 patients will actually manifest hyperglycemia. And that is the reason that you need heightened monitoring here. So you can't say that ward I am monitoring at twice in the day, ICU also I monitor twice in the day. It cannot work that way because we know that you have to pick up this hyperglycemia much higher than that in the ward. Clear? Because the hyperglycemia incidence is higher. Clear on this? Any doubts till now? Okay. So why do they get hyperglycemia? So the reason is why do they get into this? What happens when you get hyperglycemic, Arshad? What are the hormones that you release? What will happen? What will you release?
Insulin.
No? What happens as a counter-regulatory hormone? So there are 3 things that you have to release, no? One is glucagon, as you rightly said. Then cortisol. Then hormones that will adrenaline, epinephrine. Okay. So there are 3 hormones that are released anytime that you are under stress. Okay. One is glucagon. In stress, now because we are talking about stress, what happens when they stress? When they stress, you release glucagon. It's a counter-regulatory hormone. You release epinephrine and release cortisol. Now what happens with all these things? What happens with all these things is that they create something called as insulin resistance. So even though your body is secreting insulin, that is not enough to counter this problem. You understand? Also what happens in the ICU is the fact that there is a change in the GLUT4 receptor, that is a glucose transporter receptor. There's a change in the GLUT4 receptor which is very commonly seen in ICU. Because what we are trying to figure out, why in ICU you are having this 15%? Why in ICU you are having this 15% is what we are trying to figure out. Okay, whereas in a hospital environment it's so less, why in ICU environment this is going so high? That's the question that we are trying to answer. Are you understanding? But that is because of the fact that in the intensive care unit, this GLUT4 expression is also changing. Okay, because of the stress response that is there. And the third thing is, at this stage, there is going to be a complete change in the cytokine response. Okay, cytokine, TNF alpha, which also contributes to this and this. Okay, these are changing. Cytokines, TNF alpha, these are changing. And that's what's causing this kind of stress hyperglycemia. Right? So you do have glucose, cortisol and epinephrine which is kind of releasing, which actually causes insulin resistance, and at the same time GLUT4 receptors are changing, which actually causes the insulin resistance and cytokine. And on top of it, we have an iatrogenic problem in our ICU. And what is the iatrogenic problem? The iatrogenic problem is we give them feed when it's not supposed to be given. We give them TPN when it's not supposed to be given. We give them dextrose when it's not supposed to be given. Right? So we give them, but we give them. We have to give them because we need maintenance fluids. We need fluid to go into. It's not just the glucose. It's also the water. Right? We need to give the water. We need to give the nutrition. We need to give the protein. Unfortunately, along with that, glucose goes inside. Unfortunately. So the addition of TPN and all of these things per se and immobilization together again causes the sugars to go up. And that's why stress hyperglycemia is a phenomenon that occurs inside the intensive care unit. Right? Clear on this? Stress hyperglycemia. Alright, so again I'll repeat the whole thing. You start by saying that only 2.8% of the population or 100 will actually be diabetic, but when it comes to intensive care units, it becomes almost 10 times. Okay, and the reason why it becomes 10 times is because of the fact that there's a huge amount of counter-regulatory hormones that are getting liberated, along with GLUT4 receptor changing, co-transporters, the inflammatory markers that are changing, and the presence of iatrogenic complications, or for that matter, I don't call it iatrogenic, it's necessary evil that occurs, which actually causes the glucose to go up, causing stress hyperglycemia. Clear? Clear? Now, stress hyperglycemia, if you think about it, whatever happens in your, what is the best machine in the entire system, in the entire universe, is your body. Okay, this is the best system available, a best system. So, masterly inactivity is something that is one of the sine qua non of critical care. If you can masterly be inactive to understand when I have to intervene, that is very important. Okay, when I have to intervene. Okay, that's very important. So whatever happens in the body is usually a response to protect the body. So, needless to say, even stress hyperglycemia could actually be a positive factor that is to your body. So the big question was, let's not treat this. And long ago, it was let's not treat it. Up to 2001, don't treat it. There's no point of treating this because it is a defense mechanism of the body. That was the thinking. Okay, let's not treat this. Leave it at where it is. There is no point of treating that. Because why? One of the things that you can probably look at, one of the things you can look at in such cases is stress hyperglycemia. Chair लेना मत ऐसे. अच्छा जरा इसको बोलो मेगा कॉपी करने के लिए. Yes, yes. So one of the things that you look at when you look at stress hyperglycemia, where is stress? Why is it positive? Why is it good? Why do you think it could be good? Gokul, why do you think it could be good?
So it can revert once the stress is.
Why could it be good? Why is it a good response? Why do you think it's a good response? See, as I told you, whatever the body does is usually to protect the body. Okay, it's usually to protect the body. What does the body does? Okay, it depends on how much level it tries to protect.
It try to reduce the hypoglycemia, which is because of the.
See, what is happening in any kind of stress response, or for that matter, any kind of problems with respect to perfusion, is the sugar and the oxygen is not reaching. The issue why we all have a problem is because our blood oxygen is not reaching to that particular place, right? So the amount of oxygen and blood or sugar reaching to that place is less, and that is why this is one of the defense mechanisms. You understand? This is one of the defense mechanisms, that the glucose goes up, so that whatever glucose reaches the brain, whatever glucose reaches the end organs, whatever glucose reaches the kidney, everywhere it reaches, so that there is no hypoglycemia in those particular end organs. So this is one of the protective mechanisms of stress hyperglycemia. So that is one of the reasons that we thought, let us not interfere with that. This body's mechanism to do whatever it needs to be, whatever needs to be done. The second defense mechanism, you can think this way, that what happens when you have stress? What happens when you have stress? So first thing, you have stress, you know what is happening. You are basically, you will hold on to the water, you will hold on to the sodium. That's what happens in stress. You will hold on to it. Why will you hold on to the water and sodium? Because that's what the defense mechanism. You want to maintain the pressures. You want to maintain the pressures inside the body, because that's how blood and oxygen will go everywhere. That's why you hold on to the water and you hold on to the sodium. You understand? We discussed that when we did SIDH also. When we were holding on to the water at particular moment. Right? What does stress hyperglycemia do? It creates an osmotic diuresis. So it will not allow excess volume overload in stressed patients by actually causing some amount of osmotic diuresis. This is also one of the theories. So one of the theories was, it is increasing the glucose so that it reaches everywhere. It is actually causing osmotic diuresis, okay, which will actually help reach various parts of the body, stress hyperglycemia. Clear? And also we know from studies in the past that glucose used to stimulate the cardiac system. Okay, we know from studies in the past to the extent that when long ago in CABG patients, when they used to do CABG post 1970s to 1990, even up to 2001, they gave glucose so that the cardiac system could be stimulated. So theoretically, stress hyperglycemia will actually stimulate the cardiac system. Okay, so this is the good part of stress hyperglycemia. We also want to understand what would be the extent that can cause problems when it comes to stress hyperglycemia if you treat them. So iatrogenically, stress hyperglycemia can be dangerous because if you treat them, it may cause hypoglycemia. So iatrogenic problems are with stress hyperglycemia if you treat them, which cause hyperglycemia. Other way around, stress hyperglycemia can be harmful. What can be harmful in stress hyperglycemia? What can be harmful in stress hyperglycemia is the fact that the osmotic diuresis itself might actually cause these patients to get dehydrated and have electrolyte imbalances. Okay, the osmotic diuresis itself may have its own set of problems over here. Stress hyperglycemia, sugars going up, as one of the slides did mention, that it actually causes reduction in neutrophil chemotaxis, and thus it causes an immune paralysis and immune dysfunction. Okay, so what's going to happen with stress hyperglycemia? There's a problem with neutrophil chemotaxis. When you say neutrophil chemotaxis is reducing, this means that the ability to fight an infection becomes kind of lower, and this is immune dysregulation. So you'll probably have even immune dysregulation when it comes to stress hyperglycemia. The other thing is stress hyperglycemia will cause the liberation of various kind of glucose, glucagon, epinephrine and cortisol, counter-regulatory hormones, which has got its own set of side effects. It got its own set of side effects and causes vasoconstriction. It causes vasoconstriction. Okay, so there is an element of vasoconstriction that develops, which can actually reduce perfusion to various organs too. So it's not this way that stress hyperglycemia is always good. It can be bad too. Okay, that is the reason that Leuven started studying this. Leuven is an ICU in Belgium, where Vandenberg, a very famous lady, very famous person, in 2001 studied what was happening at this stage. They looked at 1500 odd patients, 1500 patients, not a small number, 1500 patients they looked at. And in that patients, what did they do? They actually looked at a whole group of surgical ICU patients. Which ICU? Surgical ICU. Okay, but remember this, because this is something that you should know, not just because it is one of the starters of randomized controlled trials, but also because of the fact that this usually is something a topic of discussion whenever you are giving your intensive care, whenever you are sitting in a group. Okay, so what did Leuven do? What did Geert Vandenberg do in Leuven ICU is they actually looked at two groups. One that they tightly control. When they say tight, it means 80 to 110. Okay, versus a liberal that is more than 180. They looked at this kind of group. Okay, they looked at this kind of group where they looked at tight versus liberal glucose control. Which kind of ICU this is? Surgical ICU. Okay, this is surgical ICU. Now abroad, in surgical ICUs now, they've got a very high propensity to start the patient on TPN and dextrose. Very high propensity. So what happens in these cases is that they normally start the patient on TPN on day 1 itself. This is how this Belgium ICU functions. Okay. Not only that, they've got a very strict glucose control protocol. Extremely strict. If you look at the Leuven protocol, it's very strict and it doesn't allow even 81 or 111. 80 and 110 ke beech mein, it's very tight, extremely tight with the amount of insulin that they use. It's an extremely tight protocol. And what they proved over here was something very, very alarming for all of us. It actually dropped the mortality by 32%. Now, 30% mortality difference is like a huge amount. When we're looking at 2% and 3%, when we put trials, we say to maximize the power, we look at 10% difference. Whenever you make a trial, you want to make a trial in such a way that you want to make a difference, right? To make a difference in mortality, that's how you think. And what we normally say to make a power of a study strong is to have a mortality difference of more than 10%, or a change of length of ICU stay by 10%. 10% is the amount. This is 3 times. It changed. So this made us all think, wow, this is unbelievable. And when I did my practice, we were hell-bent upon keeping 80 to 110 because this was a huge difference. I mean, we've never seen such difference in mankind. Seen such difference. You understand? 32%. So this kind of difference came in, and we were all went into that mode where we were using 80 to 110. Very difficult to maintain 80 to 110. It is such a small number. It is such a small number, within 1 hour it changes. It is so difficult to maintain, and we were also wondering how Leuven ICU was maintaining this. But we were all hard pressed, half hourly, one hourly we were doing insulins to get that 80 to 110 fraction. What we didn't realize was that this was completely one single center study. It was though it was showing huge power, huge improvement, it was still a single center study. It was done in a surgical ICU, and it was done in an ICU where there is a huge amount of TPM use, which is not the way how we normally work. We have a mixed surgical ICU, mixed medical surgical. Very few hospitals in the world have got just surgery. Everyone will have surgery with something, medical with something. It's like that. You got the point. So it was not a generalizable study, but still there were many investigators after this who tried to replicate this. None of them got replicated. So in 2005 or 6, I think 2005 or 6, Leuven repeated this in her. Leuven ICU repeated this in the medical ICU. Vandenberg repeated this in the medical ICU. He did the same thing in the medical ICU, where they actually looked at this same tight control in a medical group of patients. And surprisingly, what happened here was that there was no change in mortality. Now here there was a 32% change in mortality, whereas there was no change in mortality when it came to a medical ICU patient, where they didn't use TPA, they didn't use dextrose. However, what they did prove, if you read the subset of that particular trial, they still said that if you had a length of stay of more than 3 days, the mortality difference was evident. But remember this: whenever you do a trial, your primary objective is actually the main objective. Okay, so you normally power your trial, you normally make a study based on your primary objective. You start your trial on a primary objective. So we normally look at a primary objective. We don't look at the sub headings. So as a trialist, as a purist and trialist, this study was after 3 days wala jo data came out was probably thought about later on. You understand? That was not the primary objective, but they did have a signal of benefit when the patient stayed more than 3 days. Right? So when this came out this way, and they found out, but when they put the whole thing together, when they put all the patients together, forget the 3 days, forget all these things, they put all the patients together, there was a signal of harm. There was a signal of harm that came in. Signal of harm is unacceptable. So there was higher incidence of how they died. Cardiovascular mortality. Just not hypoglycemia, it was actually cardiovascular mortality. They died because of cardiovascular mortality. Okay, so those patients who were admitted to the medical ICU, who received strict tight glycemic control, they died because of cardiovascular mortality. Are you understanding? And the incidence of hypoglycemia was high. They died because of cardiovascular mortality, but their incidence of hypoglycemia was very, very high. Okay, they didn't die of the hypoglycemia, but they died of cardiovascular mortality. Right? So this was a signal of harm. Once this came in, everybody said, "Boss, we should probably get back." And you will not believe it, we completely changed the practices again. We were all. I remember Dr. Zirpe in my final tell me, "Sugar, dekhta nahi tu." Aisa karke he had given me so much of gali he had given me once. Okay, for one night. I remember that because it was such a big difference in mortality. 32% difference in mortality. So it was he gave me 2 extra duties because of that. I remember that. Okay, but then 3-4 years later, everything changed. We went back to a situation where let's not do this anymore. Okay, and we were all confused. Everyone across the world were confused what is to be done. That's when Simon Finfer, another Australian fantastic gentleman who comes up with one of the best trials in the world, Simon Finfer. Simon Finfer is from Queensland, in Australia, Sydney. Simon Finfer went ahead and came up with a beautiful trial called as a nice sugar study. One of the largest trials ever in the history of critical care, sepsis for that matter, and glucose control, where he looked at nice sugar study. Now this was 1,500, this was 1,200 patients, he looked at 6,000 patients. 6 times the number of patients. 6 times, okay. So he looks at 6,000 patients, which definitely increases the power of the study. Okay, 6,000 number, this is a very large number. 6,000 means you're really a very large number. And looking at Australian trials, they are very particular. Australia has got an ANZICS group. Australian New Zealand investigative group is there. It's called the ANZICS group. Now we have an Indian group also now. We have started an Indian group. But an ANZICS group has started, which the trialists have been doing trials for ages. Senior people have been doing trials for ages and been doing the trials the real way. They've been giving us a lot of answers. Okay. Similarly, they did this nice sugar study, which is now the benchmark. which is now presently the benchmark. Okay, what is this nice sugar study? They actually looked at tight glycemic control versus somewhere between 140 to 180. So they treated only when it was more than 180, but tried to maintain the sugars between 140 to 180 versus the 110 category. And what they found was that you are not supposed to do the 110 to 80 because it causes extreme amounts of hyperglycemia and problems, and it is always better to actually have 140 to 180. So signal of benefit was equivalence was there with signal of benefit towards 140 to 180 and harm towards 180 to 110. So now that is why we have now taken that as the benchmark, and now the Society of Critical Medicine actually says treat only if there is 2 consecutive more than 180 milligram per DL, okay, and keep the sugars between 140 to 180, preferably less than 180. This is what it says. Now remember this is a mixed group of critically ill patient. This is a mixed group. How do you take this guideline now? This is a mixed group, okay. You will not use the same 140 to 180 when you are looking at diabetic patients and brittle diabetes. Remember this, okay, because what we discussed, if you have glycemic variability or high glucose in non-diabetic individuals, this is extremely dangerous. But if you have sugars on the higher side with diabetic individuals, it may not be as dangerous as that. In fact, there is benefit in diabetic patients to keep it up to 220. Okay, so I am not really very worried. So we take the middle path. In diabetic individuals, let it be 200. Let's not really go down to 140 because we know diabetic individuals will die because of hypoglycemia. There is a signal to mortality with hypoglycemia, but there is no signal of mortality with hyperglycemia. Okay, mortality is something that we should not chase anytime. Are you understanding what I am saying? So if you are a diabetic individuals, it is okay if we keep it at 200, no problems per se. Are you understanding? It is okay to keep it at 200. Now, as a doctor in the ICU, can you actually figure out right on day 1, this patient has got a high chance of multi-organ dysfunction syndrome? Yes, you can, by actually looking at the HbA1c. Okay, there is something called stress hyperglycemia ratio. Stress hyperglycemia ratio, which is basically your plasma glucose in admission divided by not HbA1c. It's a figure. I think 26.9 into HbA1c minus 46.7 plasma glucose. I think this is 27 or 26. Okay, so this figure that is plasma glucose divided by 26.9 into HbA1c minus 46.7. This ratio is called a stress hypoglycemia ratio, and this is linked to multi-organ dysfunction syndrome if it is more than 1.14. Okay, if it's more than 1.14. So this is something that you can do, which can actually tell you whether this patient can go into multi-organ dysfunction syndrome. And maybe some 1 or 2 points here and there, I don't exactly remember. This is somewhat what it is, stress hypoglycemia. If you can open it on the net. So stress hypoglycemia ratio is called. Okay. So this is something that you can do on admission when the sugar comes inside. Right? Now let us categorize them into different parts now. This is about hyperglycemia and what numbers. Now we know the number. What is the number? The number is 140 to 180. This is the number that we need to keep. 140 to 180. Okay.
So admission blood glucose divided by 28.7 into HbA1c minus 46.7.
For 28.7, sorry. 28.7. So this is a figure. So you will have some numbers which you should remember. Okay. Sometimes in studies now you may have some numbers. So one number that they will allude to is stress hypoglycemia ratio. The other number that they will allude to is called as maximum amplitude of glycemic excursion, MAGE, maximum amplitude of glycemic excursion. Then there is something called glycemic lability index, GLI. Okay, what is all these things? What we realized was a certain number was causing a problem, but what we found later on was the variability was a bigger problem. What they found was the variability was the bigger problem. Are you understanding? That's why many studies after this protocol came, about 140 to 180, there were umpteen number of studies that looked at variability. We had a target that was achievable. 140 to 180 is achievable. You understand, 140 to 180 was achievable. So we were all achieving 140 to 180. We can easily keep it at 140 to 180. We got a good number, okay, to look at. But what they found at that stage was all these trials, they started looking at variability. And to define variability, there is no specific definition. So they came up with all kind of figures like glycemic lability index. It's another equation. There is maximum amplitude of glycemic expression. That is one thing. Then they came up with something called TITR. That is time and therapeutic range. We used in our study. We used TITR. Okay. We did a study of 7G protocol, which is the protocol in the hospital. 7G protocol, which is there in literature, which has been published. That 7G protocol used TITR. That is time in therapeutic range. So they looked at variability with different ways. Okay, they looked at variability with various ways, and they found out variability is a bigger problem than actually the absolute count number. So now the entire push towards is to reduce the variability. You understand? You cannot go from a 80 to 200 and then after some day 6-7 hours we are 140 to 180. It has to be less variable. The maximum amplitude should be lesser. The maximum dip should be lesser, it should be less variable and remain in that particular area. That is why nowadays the entire push is towards continuous glucose monitoring. That is why the entire push is towards something called CGM. What is CGM? Okay, so how are the ways you actually look at glucose? How do you actually look at glucose? What is the way you diagnose hyperglycemia? What test you do? What is the test used over here? HGT. HGT is what? It is a point of care device, fastest device. You cannot have anything faster than that. There is nothing faster than that. It is the fastest device available at this moment to actually diagnose any investigation. It is the fastest. Okay, glucometer. You just put a finger stick, you put it within seconds, you get the readout. Now there is a problem, inherent problem when it comes to glucometer in intensive care. What do you think the problem would be? What do you think the problem would be? What do you think, Gautam, Gokul, what do you think the problem would be? You registered for the mechanical maintenance workshop?
Yes, sir.
Register. You have registered. You will be required for the hospital. Next time you will be faculty. This time I am taking him as faculty. What do you think will be the inherent problem? Arshad, what is the problem? Glucometer का क्या problem है? See, first of all, these patients are hypoperfused. These patients are having vasoconstriction, microcirculatory damage are occurring. There is going to be microthrombosis. Okay, so you may not get the right number. It will usually underestimate or overestimate. Usually underestimates. Okay, the glucose levels. Okay, so in a patient who is critically ill, who is having hypoperfusion, who is having all kind of sorts of problems, this glucometer may not be the right value. And that is precisely the reason that tomorrow when you have a hypo or an extreme hyper, please send it to the laboratory. One of the reasons to send to the laboratory. You understand, no? So if you have a sugar that is on the lower side, it is important that you send this to the laboratory and verify that. You may don't wait for the reports to come. You treat it. Okay, but you send it to the laboratory to be certain that this is what it is. You understand? The earlier glucometers had its own set of problems because when there was peritoneal dialysis occurring, they used to use dextrose in that particular, which used to maltose, which used to actually interfere with the glucometer, but that has also gone off. Initially it was glucose hexokinase method, glucose oxidase method. Now that is all moved. Now glucometers are superior. They don't have this PD problem. So you might see sometime in your reading that PD interferes with glucometer. It was earlier that way. Okay, peritoneal dialysis, because it used to use isomaltose and the investigation, the test used to use something very similar to that and used to pick it up wrong. So that was another problem with glucometer. So the third problem is you don't want to keep pricking your hand, no? So that's another issue. You don't keep pricking your hand because every time you prick your hand, tomorrow there will be a gangrene in that hand. Have you all undergone glucometer monitoring anytime? When did you do? During COVID. How painful it was, no?
Yes,
Unbelievably painful. Really, I'm telling you, COVID taught me what pain is. That Flexane. Oh my God, that insulin it was crazy, and it really pains. It really pains. If and you imagine they poke the same place again. You have only 10 fingers, yeah, you can't poke the toes. So they poke, then they poke again. 3-4 दिन के बाद वही आ जाता है यार, दिमाग खराब हो जाता है. मतलब 3-4 क्या 2 दिन में हो जाता है. फर्स्ट डे में पूरा खत्म हो जाता है, फिर दूसरे दिन में चालू हो जाता है, वापस उधर का उधर ही. Very painful. So that is something that is very problematic. So our entire thing is to reduce pain. When we are working as doctors, one of the things that we have in our mind is to actually reduce pain, and we actually inflict pain with this glucose monitoring. Right? It is very disastrous actually. So what is better than that? What do you think is better than that? No, what is better than that? What is a better method to monitor?
Long-term monitoring IGB.
No. What is the better in ICU? ICU there is no long term. ICU you have to monitor every hour. Which will be the other monitoring that you'll do?
ABG.
ABG. Okay, so whenever you're doing an ABG, get the glucose. So worldwide they have moved from the glucometers to ABGs, but it's very expensive in our country. Okay, the point of care. The other point of care that is fast, quick, and also valid is the ABG. It is more valid, more closer than to the gold standard. Which is the gold standard? Venous glucose. Okay, what is the gold standard? Venous glucose. That means taking glucose from the central line or taking glucose from the blood and sending that to the laboratory is the gold standard. So we are comparing everything to the gold standard. Of course, that takes time, so we can't do that. So the closest alternative you have is a blood gas machine. Okay, but worldwide, the use is of glucometer only. Because as expensive it is here, it is expensive there also, because you're doing 24-30 measurements in a day. 20 measurements in a day, blood gas, just glucose, would be very, very expensive, whatever country you are from. Okay, but on a theoretical perspective, ABG would be the closest point of care device for accurate glucose monitoring as compared to this. Now, what you hear is CGM. What is CGM? What is continuous glucose monitoring? What is CGM? What have you heard about CGM? What do you know about CGM? You have heard CGM? CGM. You should know this, okay? At least if you would have heard this CGM, right? What is CGM? Have you seen it?
Yeah, that is a transcutaneously monitor.
Have you seen it?
Yeah.
कैसे दिखता है वो?
So Steve.
नहीं. You have not seen it. Who has seen it? When I ask you who has seen it, whether has seen it, you must tell me yes or no. Because if you have not seen it, then I can find out that you have not seen it. So it's a very small round. एक प्लास्टिक जैसा होता है, वो इधर लगा हुआ रहता है. एक प्लास्टिक जैसे इधर लगा हुआ रहता है. Okay, it's a small device that is applied over here. It's applied here. Some people apply it. Some people apply it here. एक छोटा सा device. There are two kinds of it. One is prospective, other is retrospective. Now, what is a retrospective? Retrospective is CGM is there. Then you take the reader and 24 hours का वो तेरे को reading बता देगा. That is retrospective. 24 hours. What does it do? It gives you the average glucose of 5 minutes. Every 10 seconds it actually monitors. Every 10 seconds it monitors, and it gives you the average glucose every 5 minutes. So you will have a readout of 24 hours of every 5 minutes. That is what is CGM. You understand? So retrospective means this is there. Later on there is a monitor that is there. That monitor you take out the chip, you put it in the computer, and you get the readout. The prospective one is the one that is called as, it's now used, the one that is available is called a Libre, Libre CGM, okay, which is now a device where you take a mobile phone and you just keep it over here and you get the readout. Immediate. That particular moment you get the readout. So it's CGM, complete CGM, okay. That's called Libre. It comes from a company called Libre, and they are the only manufacturers presently of that. Libre, okay. So Libre is one of those CGM kits. So now, as time is going to go, since we've understood variability is a problem, and they have proven that the variability does come down if you were to do continuous glucose monitoring, in the near future, we may see intensive care also being used with CGM. And many parts of the world are actually now trialing CGM in intensive care, because we've understood that variability is a bigger marker and CGM actually reduces variability. Clear? Clear on this?
How does it measure transmitter?
Interstitial, it actually approximates the interstitial and the venous blood. So it gives you that level of glucose. That is how it is. Okay? It uses the same method, but it does it on a continuous basis. So it costs 4,500 rupees. That thing costs 4,500. Normally the company gives the machine free, something like that.
It's very cheap then.
Yeah.
Cheaper compared to.
Yeah, it is. So people should know about it. It is cheaper, much cheaper than using that still, which is expensive. Doing that is expensive. You understand? Readout is expensive. You charge that money. So it's actually cheap. But I don't know. So I'm just in a talks with a company for we want to do one trial. So I'm just in talks with Dr. Kalwalkar, so that we can do one trial on CGM. Something I think that's the future of intensive care glucose control. Alright, so now the biggest issue that we have in ICU is I feel it's not the high sugar, it is the low sugar. Okay, because the low sugar is very closely related to the mortality, very closely related. And unfortunately in intensive care it is even difficult. Why is it difficult? Because many of these patients are drowsy, many of these patients are already on on the ventilator, many of these patients are sedated, many of these patients have got metabolic encephalopathy. So you really cannot figure out one of the most important features of hypoglycemia, which is actually neuroglycopenic. Okay, so what are the features of hypoglycemia? If someone will ask you, how do you figure out hypoglycemia in patients in the ICU? So you should. So whenever we talk about glucose control, one of the most important thing is to find out how you diagnose hypoglycemia, how you treat hypoglycemia. It's very important, very very important. Okay, because you may not be on the higher levels. The higher levels are not controlled because it's fine, but hypoglycemia is death. Okay, and why is it death? Because it can cause, it is equal to anoxic brain damage. It is equal to anoxic brain damage. Anoxic brain damage is the most highest point of vegetative problems, isn't it? When you get anoxic brain damage, you are vegetative. Okay, so even when there is low sugars, it is very closely to anoxic brain damage. So we don't want to reach that anoxic brain damage anytime. None of our patient comes and becomes hypoglycemic and becomes anoxic. We don't want that. That is why you need to understand hypoglycemia. And as I told you, it's very difficult to understand hypoglycemia in the intensive care unit. So what would be your features of hypoglycemia? So let me divide this to you. Let's put it as CVS features. So there will be some CVS features. Which are those features? Sorry? Tachycardia. Simple tachycardia. Then patient will complain of palpitations. Patient will have sweating, diaphoresis. That all comes in the CVDS manifestation. Then hypertension. Extreme anxiety. Of course, this is combined manifestation, but these are the simple things that you figure out. So you have palpitations, you have tachycardia, you have diaphoresis, and you have hypertension. Okay, simple manifestations of hypoglycemia. So whenever you have hypertension, anytime in your ICU, don't go and treat it with NTG. First, look at the sugars. Do the simple things first. Okay, so look at the sugars immediately. This possibility is hypoglycemic, right? Then you come to the neuroglycopenic features, which is a big problem for us in intensive care unit, because of the fact that you will not even realize that this is related to hypoglycemia, because of the fact that there are too many confounding factors inside our ICU. Too many confounding factors. So in the neuroglycopenic symptoms, what all you will have? Anxiety, altered mental status. Then up to the end, there goes to lethargy, stupor, coma, diplopia, blurring of vision, convulsions, slurring. So you should know these features, because these are the features that you need to pick up at any given moment. And what is the simplest investigation to do is a bedside glucometer. It's the simplest investigation to do. You can pick up this by just doing. Don't just negate it. That is why even in when you come for a patient with NIHSS stroke scale being high, your first investigation that you are supposed to do in the ER is sugar. Okay, that is also one of the reasons, that because it's a fast investigation, it's a good turnaround time, and immediately you get answers. You understand? So there are neuroglycopenic symptoms that come in with low sugars. Okay, we have low sugar. So what do you say as low is low?
Less than 70 ADS.
So what is the ADA definition? You must say some definition. So definition is less than 54 and less than 70. That is moderate and mild and moderate. Severe is with symptoms, with extreme symptoms, where whatever it may be. So if it is 80 also, and you have extreme symptoms at 80 also, which is not related to anything else, that is called as severe. So for that particular person, that is severe.
Sir, in pediatric and adult?
No, I don't know pediatrics, but adult is high. But I don't think pediatrics will have a real problem unless they have an insulinoma or endocrine problem. I'm not, because these same guidelines are not there in pediatrics. This is more in adult population. Okay, I don't think so they would be, because their systems would be much more geared up for everything else. So, but still, this is what it is. But if you have symptoms, what is the importance as a group of intensive care doctors practicing? That you will tell the next person that at 80 also he had this symptom, and it is related to that. You have to tell that, because that would be your baseline sugars. That would be where you want to keep much higher than that.
So what about patients who are diabetic and they constantly go into hypoglycemia because of using insulin? Will that have a different range of?
No. So this is a combined range. What I showed you is a combined range. But as I told you, there has to be symptoms. So then, if you get that symptom in place, then you say, okay, that is the level at which there is a problem for this particular patient. For example, this patient at 100 may be manifesting neuroglycopenic symptoms or hypertension. So that would be his way. I want to keep it above that. You got the point? On a definition purpose, this is severe and this is moderate. You understand? Huh? On a definition purpose. Okay, as a defined definition. Okay, but as I told you again, if you get symptoms, any symptom which is unrelated to anything else, and this is the symptom that it is, then you have to give it to everyone in your unit, saying that this is the symptom, this is the number at which problems are occurring. We need to change our sensitivity threshold, or we need to change our ranges. We want to keep it between so and so range. You understand? Huh? So hypoglycemia. How do you treat this? How do you treat this? Amit, how do you treat this? Or how do you figure for that matter, hypoglycemia has come, you diagnosed it to be 50. What is your next investigation? Patient has come first time into the intensive care unit. How to treat will come to that. But what is your diagnostic algorithm? What will you do? This could be high because of just the inherent problem that he has sepsis or something. So what will you do? What are your investigations here? This could have gone low because of a couple of reasons. One could be because he's taken insulin. One because his body is not reacting well. Third is because he's got some other element that is causing hyperglycemia. Okay, so how will you now investigate? Sorry?
C-peptide.
So what is C-peptide?
It is there in the naturally occurring insulin that is formed by the body. So
Yeah.
with an exogenous insulin, you will not find it.
Yeah, the C-peptide. So if you want to figure out whether your body is creating endogenous insulin, like an insulinoma, you have an insulinoma in your place and it's creating insulin. And that is the cause of hypoglycemia, then C-peptide is something that you can do. A C-peptide level will actually differentiate between natural insulin or external insulin, exogenous insulin. Other thing you can do is insulin levels. Okay, other thing you can do is insulin levels. Okay, insulin levels can be done, and insulin levels can be picked up. However, you cannot pick up other insulin like glargine can't be picked up. The long-acting glargine cannot be picked up. Okay, but you can pick up the rest of the insulins. You can pick up the insulin levels. Okay, insulin levels. C-peptide. Then cortisol. So I will do a cortisol level because it will tell me that in the event of hypoglycemia, there has to be some elevation of cortisol. In the event of hypoglycemia, there has to be some elevation of cortisol. If there is no elevation of cortisol, means I'm dealing with something different, a hormonal pathology here. You understand? Huh? It's a completely different picture. There's some hormonal pathology is happening over here. Okay, so cortisol levels is something you'll say. So insulin levels, C-peptide levels, cortisol levels, and thyroids. Like it gives you, because it's a combined pathology of hormones usually. So thyroid you go to say for hypoglycemia. Clear? Clear on this? Of course, you will rule out other reasons which include sepsis, for which you will do CBC. The usual workup you will do that. You will work out the LFT, you will do to figure out the liver. But this is specific for hypoglycemia for a patient who comes in from ER. Okay, this is not a patient who is in the ICU. So ER say patient has come hypoglycemia 20 milligram per DL, and you want to figure out what's happening. So in those patients, you would like to figure out what is the cause of it, and that's when you do all these investigations. Not for a patient in the ICU who got hypoglycemia, because here it's because of what you already have a diagnosis in place. You already know reasons why they're going to hypoglycemia. You understand? So it's not this way that tomorrow you have hypoglycemia, so and all these levels. It doesn't work like that. Okay? Huh? So what do you do in this case? So if you have hypoglycemia, you find out these symptoms. What is the next step Amit will do? Or so what will you do in this case? What will you do? You have hypoglycemia to treat it. You did a glucometer. Okay, you found the sugars were 20. Immediately you send a venous blood glucose to the lab because you want to document that. You want to document that. There is no documentation otherwise. You are documenting that. 20 है, 30 है, और जो भी है. So.
Dextrose.
Huh?
Dextrose.
How much dextrose will you give?
25 gram of 50%.
So how much is that?
100 ml of 50%.
How much does 100 ml of 50% dextrose contain? How much grams? How much grams it contains? Simple question.
50.
Huh? You should attend the nursing lectures. It's very important that you attend nursing lectures because these are basics that nurses would tell you. You have to attend the nursing lectures, Arshad. Saturday ka lectures to attend kar. It's not help you otherwise. Huh? So 50 grams. Okay, it's 50 grams. Okay, normally 50% means make it 100, and that is 50 grams. That is how it is. So it's 50 grams of dextrose is there. You want to give 25 grams. That is what the protocol is. How much you will give? So how much you will give? 50 ml. 50 ml. Okay, 50 ml of dextrose is what you'd want to give in these cases. 50 ml of dextrose, because as I told you, variability is a problem. Variability is a problem. So there is a possibility that if you give dextrose higher amounts, there is a possibility that it will shoot up, and then you'll have a problem in getting it down. Then it remains high for some time, then it slowly comes down. You will lose 8-9 hours. So you should not lose 8-9 hours. That's why 25 grams of dextrose is what you need to give. And then you follow, if the sugar still doesn't come up, what do you do next? So you have done 25% dextrose. And the problem with 50% dextrose is what? Yeah, it's a peripheral line, boss. It's not an easy task to do 50% dextrose, because you will probably fire off the existing line you have. So normally you want to try to give 25% dextrose. So how much will you give? Double the amount. Or 100 ml. You understand? So 25% dextrose, 100 ml is what you want to give. Okay, because that is better. And even better is 10% dextrose. If the patient has no fluid problems, it is best to give 10% dextrose. How much you want to give?
250 ml.
Exactly, 250 ml. But what you must understand in the background is, this is a patient who is going into cardiac arrest. This is a patient who is going very down. So I really can't afford to give that unless I give it really as a push. 250 ml ke push kar diya maine. Unless I do that, okay, just putting 250 ml and waiting for it to go is not the way it should be done. Okay, because an average also it will take around 15-20 minutes for it to go. Our nurses will not give it fast. It doesn't go because of line and whatever. So I would initially at least give 125 gram of dextrose. And then probably use it. Why you should remember this, because sometimes you have these patients which come with very poor IV lines, you don't get an IV line, you put some very dirty IV line, crappy line. In that case, it is more beneficial to give this rather than not give anything. 50% dextrose, immediately the line will go. Okay, so if you have a crappy line coming in, 10% dextrose to 50 ml is something that you want to give. Okay, clear on this? Dextrose. So the first thing I give is 25 grams of dextrose. 25 grams of dextrose. Next, what do you do? It doesn't come up. If it doesn't come up, what is in your mind? A, that the hypoglycemia is very severe. And the second thing that comes to your mind is there something else that's causing this? Okay, is there something that is causing hypoglycemia in this patient, some medicine that is causing this? So which are the medicines that may cause this? This is kind of picture. Yeah, so which are the hypoglycemics? One of the commonest hypoglycemics that you can treat with a different drug is what? Exactly, sulfonylurea. So you can actually treat sulfonylurea intoxication, which will not relieve with dextrose, with what? Octreotide. That is where the role of octreotide comes in. Okay, so if you know that it is sulfonylurea and it is not coming up with your regular dextrose, you probably want to start 50 microgram per hour of octreotide. Okay, that's how it will probably work. Okay, in these cases. Now you have a situation where you are not giving sulfonylurea, but the sugars are still not coming up. Then what do? What do you suspect?
Insulin.
What do you suspect? Not insulin. Insulin will come up fast. What do you suspect? You'll suspect cortisol insufficiency, right? You'll say cortisol insufficiency, because at the end of the day, cortisol has to work. Cortisol is not working. That is why you end up giving hydrocortisone. 100 milligrams of hydrocortisone is given. Okay. If you ask me how quickly, I don't know. If the sugars are not coming, just give it. It's like that. If you ask me within 5 minutes, I will do 10 minutes, I don't know. Maybe you give the dextrose, wait and watch. Ideally, I expect the dextrose to immediately get the sugars up within say 10 minutes. 2 minutes, 5 minutes, it should come up. If it doesn't come up, I will give another shot, wait for it. Doesn't come up, then I will try all these things. Are you understanding? So now you have the dextrose, dextrose you have given, 50 ml you have given. 50 ml you have given. And after 100 grams, after 100 ml has gone inside, okay, after 100 ml has gone inside, that means of 50% dextrose, the sugars have come up to 120. What is your next step? Say you are given 25 grams. Let's put it this way: 25 grams area. 25 grams के बाद sugar आ गया, तेरा 120, 130 आ गया. Patient has become conscious, slurring of speech has gone, twitching has gone, eyes are better, she is not seeing blood. Patient's clinically improved. So with 25 grams, what is the next step?
We will assess the sugar after.
No. You follow that up with a dextrose infusion. You don't follow the sugar. You follow it up with a dextrose infusion. You have to do that. Because what did I tell you? Hypoglycemia kills. It has already caused almost a killer effect. Already it has caused a killer effect. I don't want to get that back. So I will immediately start this patient on dextrose infusion. Okay, what would be the dextrose infusion you would want to give? I definitely can't give 50% dextrose. I don't have a central line. I can't give 25% dextrose also because that's all. Again, I don't have a central line. Can again fire off. I'm left with what?
10%.
10 and 5%. How much will I give?
5%.
How much? How much I give? What is the rate?
2 ml per kg.
2 ml per kg. That's 80 ml per hour or 90 ml per hour of 5% dextrose. So the answer usually, is usually to give 1/4 the amount of dextrose whatever treats the problem. 1/4. So on an average, it should be 125 ml per hour of 5% dextrose. On an average, okay. Usually in 1 or 2 amount of dextrose you are actually through. Even one is through usually. So normally you start the patient on 125 ml per hour of 5% dextrose and follow this up. Not starting dextrose is very dangerous. Okay, so this you may want to alter as per the fluid requirement. You can understand this patient is having hypoglycemia. If you give 125 ml per hour, it's a good amount, very big amount you are giving. And this is nothing if you ask me. This is still nothing. 125 ml per hour is still nothing. This is 5 grams in 100 ml. You know, this is 5 grams in 100 ml. So in a 500 ml you are giving just 25 grams. Are you understanding? You are just dividing into 4 parts. Hourly you are just dividing 1/4 you are giving. Still very less. How many calories? How much calories is going? Hardly anything. If you want to give 1000 calories to a patient with 5% dextrose, how much dextrose you have to give? How much does 1 gram of dextrose contain? 4 kilocalories. 1 gram of dextrose. So 5% dextrose will get 20 grams. 20 kilocalories. So to give 1000 kilocalories through dextrose and think that is infusion, you have to give 6.5 liters. How many? So for 1000 kilocalories, you have to give how much? 6.5 liters. So tomorrow if somebody calls up and says, don't worry, we are giving him nutrition, 5% dextrose we are giving, he's a jerk of the first order. Because to give 1000 kilocalories, you need to give 6.5 liters. Nobody will give 6.5 liters for 1000 kilocalories. You understand? At the end of the day, I want to increase the kilocalories here. That is when the sugars are going to go up. So the easiest method, forgetting about all of these things, is to give him oral glucose. So the answer is to give oral glucose. That is the easiest method. Okay, not IV. Oral is the easiest method. So the moment the patient wakes up, the next thing is give him a cup of tea with sugar. It's the easiest method to get the sugar up. Most practical and easiest method. That's why when you go for a marathon, have you gone for a marathon, any of you guys? So in a marathon, what do they give you? They give you that glucose का डब्बा देते ना, but run up करके आता है, एक छोटा tablet रहता है वो. That is given to you all. Why is it given for us? Because for that matter, if you have hypoglycemia because you have not eaten for the night, you know normally what happens for a marathon, you don't want weight. So that night you don't eat, you don't drink too much of water, and you just come to run because you don't want weight in your body. You want to run a little bit faster, right? It's a completely misconstrued idea. And then they run. And then 3-4 hours they run, they become hypoglycemic. And then they fall. That's why when they get hypoglycemic, they don't die because of any dehydration. Dehydration hota hi nahi hai. But dehydration hota hai, but it will not cause your hypotension and him to fall down. वो नहीं होने वाला है. You know, unless you are in an ultra marathon. You understand? It's never going to occur. That dehydration is going to cause you to down. What causes you to down is hypoglycemia. You understand? So what do they give you? They give you small tablets which contains glucose. It's called Rise Up or something. It's called Glue Cup. It's called. You put that in your mouth and you're fine. So that's why even in intensive care units, once the patient gets better from his hypoglycemia, the next step is to just give him oral. 1 tin of Ben Jerry's, 1 tin of an ice cream, 1 small cup contains 1000 kilocalories. So now you compare. It's easier to give him an ice cream, isn't it? It's easier to give him an ice cream. 1000 kilocalories, 6.5 liters of 5% dextrose versus 1 cup of a good ice cream like a butterscotch or a vanilla will be 1000 kilocalories. So the fastest method to get up on the sugar is actually oral. It's actually oral. You know, and that is the age-old tradition of India to give everyone tea. The age-old tradition of India, we have changed it to sugarless tea and all this nonsense. But otherwise, tea was the basic reason to give tea is that there's sugar in it. Muh meetha kijiye is actually part of, don't get hypoglycemic. You understand? That is the reason that sugar is best absorbed when it is given orally. You can give huge amounts when it's given orally. So the answer in stress hypoglycemia is give orally. Okay, you have stress hypoglycemia, and we just talk about the fact that we talk about hypoglycemia and the patient gets very sick, becomes anoxic. So how will you distinguish anoxic brain injury as a result of hypoperfusion versus hypoxic brain injury as a result of hypoglycemia? How do you distinguish that?
Improvement of
Sorry? No patient is bad, no patient is vegetative in front of you. Now you want to put a cause to this. You want to put a cause to this, saying that maybe it was cardiac arrest which caused this, or maybe it's hypoglycemia. See, when you have a cardiac arrest, you have perfusion loss. The cardiac arrest could have been because of hypoglycemia. Now, whether it is hypoglycemia causing this problem or patient has come from home absolutely in a vegetative state, you need to figure out what is happening here. Is this probably because of hypoglycemia, or is it probably because of anoxic brain damage? Because both will have different manifestations on an MRI. On an MRI, it is very different manifestation. What is the different manifestation? So if it's hypoperfusion, it will be the watershed infarcts. If it's hypoperfusion, they'll be in the watershed zone, MCAC, MCPC. There will be watershed zones where you will have infarctions. Okay, that is what happens when there is hypoperfusion. Okay, when there is huge anoxia, there will be no part of the brain that is spared. There will be no part of the brain that is spared. Okay, every part of the brain will be involved. When it is hypoglycemia, the thalamus and cerebellum is spared. Okay, the thalamus and cerebellum will not light up. The T2 will not show restricted diffusion in thalamus and cerebellum. Okay, so when you are placed with a MRI where the thalamus and cerebellum is not involved, you will start thinking whether this is hypoglycemia. Is this hypoglycemia induced? You understand? So you will have a diagnosis in your hand and you look at that particular part. And how do you know the severity of hypoglycemia? By looking at the basal ganglia. If the basal ganglia is lighted up more than the rest of the places, then the severity of hypoglycemia is very high. Okay, so I'll just repeat the whole thing. So to figure out anoxic brain injury versus hypoglycemic brain injury, the only way we can do that is by actually doing an MRI. One of the ways, that is. And it is not 100%. Okay, what I'm saying is clinical features, associations. It is associated that if there is anoxic brain injury, the thalamus as well as cerebellum would be affected. But if there is hypoglycemia related brain injury, the thalamus and cerebellum is not very affected. Thalamus and cerebellum is not very affected. The second thing is to understand severity of hypoglycemia. It will be you have to look at the basal ganglia. If the basal ganglia is extremely lighted up, extremely gone, that is where you have severe hypoglycemia. So in short, when I look at the MRI, I look at thalamus, cerebellum. Okay, this is not lighted up. This is probably hypoglycemia. Then I look at basal ganglia. If the basal ganglia is very badly affected, it's severe hypoglycemia. That almost goes towards your diagnosis of hypoglycemic brain injury. Clear?
So by thalamus and this is not involved in this.
Thalamus, it is not involved. That's not the association. That's exactly the association. So, it's very rarely, when I attended one of the IFCCM exams, this was actually asked. I was an observer for a couple of IFCCM exams. So one exam had this question by one of the doctors. I was an observer because I was not the examiner. So I was the observer. They asked this question. I also didn't know at that time. And then they showed that MRI and they said, "What do you think this is?" And this is the answer. Okay. So it's a good trivia, but it's nice to know it, that this is what it is. Okay. Arshad, stop this.